All right. Well, good afternoon, everyone. Thank you for making time to come to this session where we are going to discuss metabolic health and mental illness. We'll talk about why this is important and what are some of the steps that can be taken to ensure that the best possible health is maintained. Uh, Before we get started, a note about my disclosures. I have worked with these two companies to develop products. So the second one, they were trying to develop a medication that would help with cognition, improving cognition in schizophrenia. And so I was a consultant for that. And the first company provides the clozapine in our system. And I have done talks for them, although I don't decide which company provides clozapine in our system. Um, Having said that, today, these are the two objectives that we're going to cover. We're going to understand the implications of metabolic abnormalities in on physical and mental health in our patients. And then we are going to review how we can help address some of the burden. So let's get started with the first objective. Let's start with the why. And this is the image on the left of the screen is Albert Einstein, a very famous person. The one on the right is his second son. His name was Edward Einstein. And he wanted to be a psychiatrist. But when he was in the second year of his medical school, he developed schizophrenia and then was treated with antipsychotics and ECTs, not very different from what would happen today. And then he died at the age of 55 years from a stroke. Albert Einstein, of course, lived on to 75, 76 years of age. And this anecdote represents this 20 years of lost life that is now becoming a well-known fact in the space, in the mental illness space. Our patients do not live as long as the non-mentally ill population. A lot of it is driven by cardiovascular risk. In the general population, we have had several gains in longevity and better cardiovascular health management, better control of things like stroke and heart attacks and high cholesterol, etc. However, a lot of that has not filtered down to patients who might be suffering from mental illness. And that is part of the reason why life expectancy for people with severe mental illness tends to be about 2 decades lower compared to the non-mentally ill. And this is by no means a new realization. This overlap between metabolic health and mental health was known as far back as 17th and the 18th century. Thomas Willis, who was a physician back then, said that diabetes is a consequence of prolonged sorrow, hinting that mental and physical health are linked. And Sir Henry Maudsley famously commented upon this overlap between diabetes and mental illness, although in a less politically correct language, back in the 18th century. Now, this understanding has since then evolved. And now we know, for example, that there is a highly interconnected web between something like diabetes and mental illness broadly, where, for example, for major depressive disorder, diabetes may function as a susceptibility factor and vice versa. So they both influence each other in very real ways. When you look at bipolar disorder or schizophrenia, these disorders themselves are independent risk factors for diabetes. And then some of the medications that we use can also worsen metabolic health. So this is a very, very intertwined and interrelated field. And then this link between severe mental illness and obesity or diabetes is not linear or one unifactorial either. And there are multiple levels of factors that play a role. So, for example, there are lifestyle factors. For a variety of reasons, patients who might suffer from mental illness and its consequences can have poor self-care. They might have high smoking rates. They may also have larger amounts or larger periods of inactivity, and for a variety of reasons have access to less healthy diet choices. There are also system factors. As much as we would like, the mental health and the physical health system do not really talk to each other very well. Physicians and teams tend to work in silos and there is poor coordination. Our policies are also not supportive at times of this coordination and improvement of mental and physical health. And so sometimes the best drugs are not accessible to patients who need them the most. And there are imbalances and lack of access in how care is delivered and is available. But then there's also the biological factor. Like we discussed in the previous slide, there are inherent links between a disease like schizophrenia or bipolar disorder and metabolic dysfunction, as seen through weight gain or diabetes. And studies at the genetic level or at the protein level have shown that these two groups of illness can actually have significant overlap. And that complicates how we think about these disorders and how we treat them. But then there are also our treatments, and our treatments are wonderful when they work and for the things that they work. So, for example, antipsychotics are very good at reducing symptoms of psychosis. However, it is well known also that they cause significant weight gain and related metabolic side effects. So, it's a double-edged sword. Without these medications, mental illness is difficult to treat, and the same applies to antidepressants and mood stabilizers. These drugs are valuable in our pursuit of treatment of mental illness. Can we have better drugs someday? Of course. This is by no means the best that we can ever have. Hopefully, we'll have better drugs. But for now, these are the drugs we have. And again, they are quite effective. So please don't go back from this talk thinking that I'm criticizing antipsychotics or I'm saying that antipsychotics should not be taken or they are bad for you. Antipsychotics are good if prescribed right for the indications that they are prescribed. They are very, very, very strong drugs, which are very, very, very effective in treating psychosis, for example, for antipsychotics, depression for antidepressants, and instability of mood. However, it goes hand in hand that those drugs have side effects, and some of those side effects include weight gain. And so this slide shows a distribution of weight gain risk across antidepressants and antipsychotics and mood stabilizers. So when you look at antidepressants, some of the drugs that cause the most amount of weight gain and related side effects seem to be mirtazapine, amitriptyline on the top, and paroxetine towards the bottom. When it comes to antipsychotics, the drugs that cause the most weight gain are clozapine and olanzapine. And then there are drugs which cause about medium weight gain, such as risperidone. And then there are drugs which are supposedly weight neutral, such as aripiprazole and ziprasidone. Aripiprazole is at the top, ziprasidone is at the bottom. However, while this is largely true, we have more data from our lab and others showing that long-term, most antipsychotics cause metabolic problems. And so while there is some variance in risk in terms of weight gain over longer term, most antipsychotics can cause significant metabolic problems. And therefore, I think as clinicians, we need to be aware of it and be proactive in treating some of these problems as or even before they emerge. Same with mood stabilizers, lithium and valproate are both known to cause some amount of weight gain. Now, there are implications of this metabolic dysfunction beyond cardiovascular morbidity and mortality, beyond heart disease and brain disease as well, because it very directly impacts medication compliance. Weight gain is now the number one reason why people stop taking their drugs. And as you can imagine, if somebody's not taking their drugs, they are less likely to do well. And so that leads to a whole series of downstream events, leading to increased hospitalization, poor outcomes, and overall higher social care costs. So this has a real impact, this metabolic dysfunction as a result of side effects of treatment. And then we have also shown our lab, this is one of my doctoral students, Kate, and my postdoc, Nicolette, who have shown that this in mood disorder, that if somebody has metabolic abnormalities, their cognition tends to be worse. I know this is a busy slide, a lot of information, but I would encourage you, if you can follow my mouse, to look at the diamond at the bottom. This shows what is the summary effect of all these studies that have examined it. And the summary effect suggests that if somebody has a mood disorder and metabolic dysfunction, their cognition is measurably lower compared to somebody who has the mood disorder but not the metabolic abnormality. And similar work has been shown in schizophrenia as well. Now, while we are increasingly realizing that metabolic dysfunction is a big problem and that it needs to be treated aggressively and early because it has such impacts on our overall quality of life and outcomes, we are not doing so well as a field in dealing with it. So these are landmark data from a study that is more than a decade old now and represents data from 34 community health facilities in the US. the individuals included in this study are young people. The mean age was 20 years, and they have been exposed to about 3 months of antipsychotic treatment. All of them have received antipsychotics for less than 6 months. The mean is about 3 months. And as you can see, even so early on in their course of illness and treatment, more than half of them have developed changes in lipid profile. More than 15% already have prediabetes, and about the same number have metabolic syndrome, which speaks to such a big problem that happens so early on. I mean, these are young 20-year-olds who are already saddled with metabolic problems, on top of the psychosis diagnosis as disruptive as that is. And then if you look at the light bars, which is the rates of intervention across these participants, you see that it's uniformly zero across the board, except for some treatment for high blood pressure, which again underlines the point that in most systems across the world, while there's increasing recognition of this problem, we have been historically slow to treat and react. And again, that speaks to the systemic challenges we have. Psychiatry has traditionally thought of weight gain and diabetes as not its problems, and so it gets farmed out to the GPs, for example. GPs are overloaded, and sometimes they may not be aware of the evidence around this particular area, and they might wait till somebody develops diabetes or hypertension before they start treating it. And so early stage treatment gets sort of falls between the cracks because neither the psychiatrist nor the GP is sometimes able to step in for a variety of reasons. So to summarize this first objective, the cornerstone of our management strategy, which is pharmacology in terms of antipsychotics, antidepressants, etc., they can be very effective in managing the primary symptom, but they can cause metabolic side effects. And these side effects add in real terms to the burden of illness, to the experience of illness. And therefore, we need newer targets and strategies to deal with this problem. And so in the second half of the talk, I'll try to show some of the strategies that can work and some of the things that we have done here at CAMH, and hopefully that can guide the way forward, because I truly believe this is an addressable problem and this is a treatable problem, and that the longer we wait, the worse the problem becomes, and therefore we need to be proactive about how we manage this. Right, so then let's discuss what possible strategies could exist. If somebody has metabolic problems as a consequence of their treatment, what could you do? So broadly, there are 4 possible strategies. Somebody could reduce the dose of the medication they were taking. You could switch from one drug to another drug. Then there are non-pharmacological interventions like diet, exercise, CBT, and then there are pharmacological compounds that can be added on to help with this. So let's go through them one by one. Lowering antipsychotic dose. I'm going to use antipsychotics as an example because that is where most of the data is, since weight gain is such a big problem with antipsychotics. The data with antidepressants and mood stabilizers, unfortunately, is not as rich, but we can discuss that in questions and answers if you have specific questions around that. So when it comes to antipsychotics, lowering antipsychotic dose is not really a good solution because it does not appear that the weight gain is associated with dose, and lowering the dose too much can result in increased risk of relapse. So ideally, this is not a good idea. And then there are switching strategies. So you go from one drug to another. This has also been studied, and it seems that it works in a certain amount of certain number of circumstances. If you're going from a very high liability agent, such as an olanzapine, to a relatively low liability agent, such as aripiprazole, then it might work. However, outside of this strategy may not be great. Also, there is a risk of relapse every time somebody switches from one drug to the other. And so this can work sometimes if enough time and discussion happens and if somebody is on a high liability agent, but it may not work for everyone. And then we come to non-pharmacological interventions. And so, I mean, this goes without saying that everybody should be watching what they are eating and exercising as frequently as they could. So some of the strategies we use in our clinic is to ensure that everybody is walking every day, about 30 minutes every day, and trying to reduce add-on sugar intake. So whether it be in terms of pop, even diet pop, or fruit juice, or sweetened yogurt, etc. So we are trying to reduce cookies, candies, you name it. So we are trying to tell people to reduce their sugar intake and making sure that they're reasonably active. Again, I'm not a dietitian or somebody with expertise in exercise, so I may not be able to answer specific questions about specific kinds of diet. And I know some diets are quite the rage now, but our focus in general in the clinic is to ensure that people do sustainable things and eat generally healthy. Smoking cessation is a big one. I listed it under non-pharmacological interventions, but you can use, there are drugs that can help somebody quick, but smoking cessation is one of the biggest things that somebody can do to improve their cardiovascular health, and that also should be explored when reasonable. And then come pharmacological interventions. This is where my group, my lab has the most expertise. And we have done a bunch of studies using a variety of methodologies and found that metformin, which is a commonly prescribed anti-diabetes agent, it's very safe and effective. It has been around for over 8 decades now. We have found that it is effective in not only treating, but also preventing antipsychotic-induced metabolic dysfunction. And so we have actually been part of guidelines to say that metformin should be thought of proactively and early on, because we have evidence showing that the earlier you start metformin, the better it is. And we have separate evidence showing that prevention of this metabolic dysfunction is actually safe and feasible using drugs like metformin. We did a chart review of all the patients that we had in the clozapine clinic and the metabolic clinic here at CAMH, and we found that people who were started on metformin together with their clozapine gained almost no weight in 1 year compared to people who were on clozapine alone. They had better fasting glucose, they had better cholesterol levels, and interestingly, they were more likely to continue to be on the clozapine. So that's very interesting, because people tend to fall off or stop taking clozapine at 1 year. Only about half of the patients who started on clozapine tend to be on it at the 1 year point. However, people who or individuals who were taking metformin and clozapine together, 65% of them continued taking the drug, suggesting that if metabolic dysfunction is handled, probably we'll see an improvement in adherence, which sounds logical, but it has not been shown yet. And so we were one of the first groups to show this. And so we think that's interesting, and that should motivate psychiatrists to think about these treatments. Other than metformin, our work has shown that topiramate use is also supported by evidence. Topiramate is used as an anti-seizure medication or for migraines, but it has an off-label use where it can help reduce appetite as well. A combination of topiramate and phentermine is actually approved as a weight loss agent in the US, not here. And so we have found that topiramate can help with weight loss. Topiramate has a bit more in terms of the side effect load. It can cause some slowing, cognitive slowing, and tingling sensations in hands, in fingers and toes. And so metformin can sometimes be a bit more acceptable. However, topiramate is a very good option that should be a part of our toolkit. And then, of course, there's a lot of excitement around GLP-1 RAs, which is a new class of drugs. So drugs like Ozempic and Wegovy and Zepbound and Mounjaro, which is there's a lot of media attention towards these drugs. In our clinic, we were the first to show the efficacy of semaglutide in those who are being treated with antipsychotics and had stopped responding to metformin. So we gave it to 12 individuals and found that they lost about 8.5 kilograms of weight in 9 to 12 months, even after they had stopped losing weight with metformin. And we are currently running a clinical trial that is funded by CIHR to examine if semaglutide would be a safe and effective drug in patients with antipsychotic-induced weight gain. So the evidence is still accumulating. There are a lot of unknowns about drugs like Ozempic. We don't know long-term efficacy and safety just yet. Overall, they seem reasonable, but then you never know because it's so new. And every day there's a new news article either saying that there's a benefit of these class of drugs or there's an unknown risk that we just found out about this class of drugs. And so it's a fast-moving field, and we are still sort of trying to understand all the things that the drug does. We do prescribe this drug when indicated in the clinic, and our response so far has been usually good. But then there are side effects such as nausea, vomiting, constipation There are certain things that get contraindicated if somebody's on semaglutide, like ECTs. You can't do ECTs. But then again, we can discuss this more if somebody's interested. So this slide shows a very preliminary data from our clinic. We are doing a full audit of our clinic for the last several years, and these data represent more than 300 patients. And what it shows essentially is that for a majority of our patients, we are able to bring about 5% body weight loss. So when we looked at the data, more than 40% of our patients experience 5% weight loss. 5% weight loss is interesting because it has been shown that 5% weight loss causes a significant reduction in diabetes risk and heart attack risk and stroke risk. So that's sort of the parameter of success. I know that 5% weight loss is not everything. I mean, for somebody who has essentially doubled their weight, 5% will not move the needle by much. But that's sort of the indicator of success we use at a group level. And we use a variety of pharmacological and non-pharmacological strategies. It appears that non-pharmacological strategies in gray, while may be effective in some people, may not be effective by themselves. And so in a majority of our patients, add-on medications such as metformin, topiramate, or semaglutide might be useful. And so those are the data from our clinic. And so to conclude this talk, and hopefully we'll have enough time for questions, there are very high rates of medical comorbidity, including diabetes and obesity in the population we serve. And there are, in general, low rates of monitoring and treatment, which is a problem because metabolic dysfunction exerts a real cost on patients and it adds to the burden of the illness. And now we have a lot of evidence to show that prevention and early treatment of these metabolic side effects is actually feasible, it is safe, and it is doable in a psychiatry setup. You perhaps don't need a specialized setup to be able to offer these services. And so in the metabolic clinic at CAMH, we accept referrals for individuals with severe mental illness and those who are experiencing, for example, antipsychotic-induced weight gain. And we hope to help them, and they get access to clinical care. Also, they get a chance to participate in research studies. At this point, I will stop and thank my team and all the funding agencies that support this work and make this research possible. And thank you for your patience, and I'm happy to take questions.
Thank you so much. We have some questions coming in. So I'll start with the first one here. So this question is, my 25-year-old patient gained 30 pounds on antipsychotics and feels very depressed and frustrated with her weight gain. If she had started metformin along with the antipsychotic, how much weight gain would that have mitigated?
Right, that's a great question, and it's a fairly common occurrence. Like I was saying, this is one of the reasons why people feel upset about treatment and sometimes can go off their treatment. So the data suggest that the studies are limited in time. Studies are typically 12 to 16 weeks. So in those 16-week studies, if metformin were started along with the antipsychotic, they have shown a 4 to 5 kilogram reduction at the study endpoint. These studies are not long-term studies, so you don't know what would happen in the long run. If started as a treatment, then metformin can bring about 5 kilograms weight loss on average. So I hope that helped answer your question. But if you're starting it proactively, I'm guessing the benefits would continue. And we don't really have long-term data, though. Some of the data from our clinic suggests that if somebody's on metformin while being started on antipsychotic, most of the metabolic dysfunction could perhaps be headed off. And so there is some advantage in starting early.
Great, thank you. Another question is asking, another participant's asking, what about the metabolic issues being the result of the mental illness and not the medication? Is there evidence of that?
Yeah. So the genetic and proteomic overlap between mental illness and metabolic dysfunction is well known. Most of it is related to diabetes, but also with obesity, and some illnesses can be can influence each other. So, for example, depression, for example, there's a study that showed that if somebody had insulin resistance in puberty while they were young, they are more likely to develop psychosis in adulthood. If they had higher weight as an adolescent, they are more likely to develop mood disorders as an adult. So there is clearly this bidirectional relationship. Uh, However, if you look at particular disorders, I mean, I'm seeing the next question from Maureen as well. I may not be able to comment on those disorders and obesity because that's not really my area of work. I tend to focus more on severe mental illnesses such as schizophrenia, bipolar disorder, and maybe depression, and their association with obesity and metabolic problems.
Great. Um, so some of the research reported the use of bupropion. I'm probably
Yeah.
not, is yeah, to curb impulsive behavior in ADD, which is a significant portion of binge eating disorder behavior. Is there any research?
Uh,
Is that being used?
So again, I'm stretching my expertise here. So bupropion has been studied as a weight loss agent. It's one of those antidepressants that does not cause weight gain and sometimes can cause weight loss. The combination of bupropion and naltrexone is approved as a weight loss agent, and so it's called Contrave. And anecdotally, it can help with, for example, smoking cessation, and then does not cause weight gain. So in limited context, they can be useful. I'm only aware of one or two studies that have examined it in the context of antipsychotics or severe mental illness, and there it didn't seem too impressive, the effects.
Mhm.
But I, again, won't be able to tell you how it works in ADD or whether it's effective in that context.
Great, thank you. Um, if patients stop their antipsychotics, do they lose the weight that they've gained?
Yeah, again, these are very good questions. So thank you, and very thoughtful questions. Uh, it depends on a few factors, including the dose of or sort of the cumulative exposure to the antipsychotic. So how long and how much. If somebody has been on it for a few years, then I'm not sure if all the weight will come off, and I'm not aware of research that shows that. Um, Clinically, when people are put on antipsychotics for their first episode, and for a variety of reasons, they go off their antipsychotic, they do tend to lose the weight, but then they also tend to get sick and have a relapse of their mental health conditions. So, uh, practically speaking, if somebody needs an antipsychotic, they should stay on that antipsychotic. And I think the weight gain should be treated by other modalities rather than by looking at stopping medication as a way out.
Great, thank you. Um, there's a question about the relationship between marijuana use and weight, and if, yeah, if you have any
Yeah, no, I
comments
don't
to
know.
that.
That's an interesting question. I don't know. I can look it up after this is done. I'm not aware. I mean, we've all heard that when somebody's high, they might want to eat more. But outside of that, you know, anecdotal experience, I don't really know what happens when somebody uses cannabis oil.
Somebody's asking, what is your experience using topramate? Uh, Contraindications, side effects, the effect on weight loss.
Yeah, yeah. So this I can answer. So we use topiramate quite commonly in our clinic. So I mean, we have been around even before GLP-1, like Ozempic, and all of that arrived, right? So back then we only had two reasonable options, metformin and topiramate, and thankfully they are both reasonably cheap and or free for most of our patients. And so we use topiramate quite frequently. In terms of indications, we tend to keep them for people who will not take metformin because we think metformin is safer and more efficacious. The weight loss in people who do end up on it is about 5 kilograms. So it sort of measures up to metformin. Side effects include some tingling sensation in toes and fingers. It can sometimes, nausea and vomiting can happen with all drugs. Very rarely it can precipitate glaucoma, but that is not very common. And because it's a seizure medication, if you suddenly stop it, somebody may be at a higher risk of seizures. But then if somebody takes it regularly, that's not going to be a problem. Um, and then it can cause cognitive slowing or dulling, which is especially evident in people who are high functioning. And so there it's a bit of a limitation of topiramate. There are no major contraindications unless there's a family history of glaucoma, acute angle closure glaucoma, where you might want to reconsider it. Or yeah, other than that, no major um, worrying signs or problems with topiramate.
Great, thank you. For patients who are taking medication for depression and or anxiety, is there any evidence that the GLP-1 medications are less effective in promoting weight loss?
Not that I'm aware of, no. GLP-1 seem to work uh, pretty well. However, if the person who's depressed or anxious is on another medication that for anxiety or depression that has weight gain causing potential, for example, mirtazapine, then the two drugs are then sort of counteracting each other, right? And so there potentially you might see some reduction effect, but I'm speculating. Um, GLP-1 trials tend to exclude, up until now, tend to exclude people with significant mental illness. There are some studies that have looked at massive groups of people who were prescribed semaglutide and then try to see if outcomes in people who had depression was any different. And to my knowledge, they have shown that not really. And that in those groups, generally speaking, the suicide risk was not higher as either. So yeah, I'm not aware of too many differences in terms of its effect based on the underlying mental health diagnosis.
Great, thank you. Another question here. What doses of metformin are used in clinical trials showing effectiveness in mitigating metabolic changes?
But yeah, the dose ranges from 750 to 2000 milligram per day and sort of follows the diabetes range. In our clinic, we aim for a median dose of 1500 milligrams. So 1000 to 2000 milligram tends to be the range in which we see most advantage.
And then there's a question about the dose of Topamax.
Oh, right. So that is about 200 milligrams shows the most benefit. People dose it between 100 to 200. So, and it's taken in divided doses, so half in the day and half in the evening. 200 milligram works better than 100 milligram if it can be tolerated.
Thank you. Um, Another participant's asking, would it be any benefit to take metformin now after taking antipsychotics for 2+ years?
Um, So, I mean, I'm assuming that metformin, I'm assuming there is some weight gain or some metabolic dysfunction that is set in, which is why you might be asking. But the answer is yes. Um, I try to think of metformin like planting a tree. The best time was yesterday, but today is not bad either. And so whenever you do it, you're likely to see the benefits of that drug. It's just that the earlier the drug is started, the more the benefits tend to be based on the research. And then again, 2 years is not too late. It's still considered early episode or first episode dish. And so you're likely to see benefits from metformin if you have been experiencing side effects.
Another question I'm seeing here is, my son has been prescribed metformin following a 40-pound weight gain over 1.5 years. He just started 1,000 milligrams per day of
Yeah.
metformin. What would the trajectory be at this point?
We typically expect 1 kilogram weight loss per month or so. And so you are expecting an average of 5 kilogram weight loss. Some people can, of course, lose more, some people can lose less. Um, and so we are looking at about 5% weight loss in 3 to 6 months. I hope that answers your question.
Great, thank you. Um, and at a previous talk, there was discussion about the GLP-1RA being helpful with addictions as well. Can you comment on that?
Yeah, there's a lot of exciting data coming out. Like I said, almost every day there's a new news report that suggests either a new effect of GLP-1 or semaglutide and related drugs, and another article suggesting a new side effect. So it's all an area of very, very active inquiry. But there is a paper out, a pretty high-profile paper, that suggests that people who are on semaglutide might have less alcohol use and potentially less nicotine use, and it might help them quit. However, these are very early reports, and um, it would be nice to see some confirmation, independent confirmation of that finding.
Great.
But it is possible. It's possible that drugs like Ozempic sort of act at a central appetitive machinery, and so uh, it suppresses appetite across various domains of desire, food being one of them. It's possible that it helps substances. There is some question of whether it can help other addictions like gambling, but time will tell.
Great, thank you. If someone is stable for 10 plus years and doing well on an antipsychotic, but the only side effect is 30 pounds weight gain, would you consider switching the antipsychotic or adding metformin or
No,
something
no,
else?
I wouldn't switch. No, I would add. It's much easier to add and monitor than switch. Switch throws in, especially given such long history of stability and doing well. Yeah, I would add every time.
Great, thank you. Um, Another question, how do you define metabolic syndrome? What exactly is it, and what are the signs and what's happening in the body?
Yeah, good question. I'm sorry if I didn't say that. No, I didn't. My apologies. So metabolic syndrome is a combination of sort of a constellation of symptoms. So we look at waist circumference, so abdominal obesity, which is combined with either worse glucose, so dysglycemia. So if fasting glucose is higher than normal, or HbA1c level is higher than normal, if triglyceride levels are higher than normal, and then the good cholesterol HDL, if that is lower than normal, or if hypertension, so if blood pressure is elevated. So a combination, 3 out of 5 of these factors that I mentioned lead to a diagnosis of metabolic syndrome. And that's pretty common with people who have mental illness and are started on antipsychotics. It is increasing in prevalence in the general population as well, but that's for another time.
Thank you. Um, which would be your first line weight neutral antidepressant choice for the treatment of depression and anxiety in people with obesity? Um, is there a
Oh, in people
preferred?
with obesity, right? Yeah, no, and you mentioned a few options. I think those are reasonable options. Um, I tend to stick with the older ones because I know them better and I have more experience with them. So bupropion, sure. But I would also like to think of estalopram and citalopram. Those are reasonable choices which do not really lead to too much weight gain. The oldest drug of all, Prozac, can actually lead to weight loss as well. So I tend to stick with those ones rather than the new ones.
Great, thank you. Um, can you comment on the interaction of cannabis and psychiatric medications?
Oh, yeah. That I can tell you. Cannabis is not good. It's as simple as that, unfortunately, within the mental health space. There is, of course, a larger population level conversation about, the legalization and the merits of that and so on. But within the mental health space, cannabis is absolutely um, contraindicated. You would like to stay as far away from it as possible. I'm a psychosis doctor, and not one day passes by without me finding another young individual who was taking cannabis and then developing psychosis. So I cannot recommend doing that at all.
Um, Thank you. So if most of the evidence is for metformin with antipsychotics, would you also prescribe metformin with antidepressants early on to prevent weight gain or even treatment of weight
Yeah,
gain?
yeah. So we in our clinic we do extrapolate the evidence because again there's so little evidence that you have to make do with what you have. So we order a broad panel of fasting blood work that includes fasting glucose and fasting insulin that allows us to calculate the amount of insulin resistance in the body. And so if somebody is experiencing weight gain with an antidepressant and has insulin resistance, then we feel confident about starting metformin. The preventative story around antidepressants is much less developed, and I don't really have any data there. And so that I would hesitate to do. But if somebody is developing problems, then early intervention sounds perfectly reasonable if it's supported by the blood values and clinical picture.
Great, thank you. Um, Another question, if I'm currently taking 300 milligrams of monthly Amplify injection, is it advisable to go to pill format or to increase the time between injections? I'm assuming in relation to weight gain.
Right. I mean, I know. I don't think that those are good options. First of all, you would want to be on the dose that keeps you the healthiest in terms of your mental health. Uh, Changes in format do not help. Increasing the time between injections can make you vulnerable for relapse unless you are on too higher dose. And so that would be a separate discussion with the psychiatrist why you think that the dose is too high. But from a purely weight point of view, these two options will not help.
Thank you. Um, Another question, why do antipsychotics worsen insulin resistance, and how does that work?
Yeah, that's exactly my research. Thank you for asking me that. There are multiple reasons why this might be happening. We don't fully understand it. So it's so antipsychotics are not simple drugs. They bind to multiple receptors in our body and in the brain. And because they bind to so many receptors, they have multiple effects. So there are theories that it is that they bind the histamine receptors and that makes people sedated and that can have an effect. They can bind other neurotransmitter systems. But our lab and some of the others have found that they can also bind to dopamine receptors in the pancreas and in the brain, and that can lead to insulin resistance and higher appetite both in the periphery and in the brain. Some of my research shows that even the very first few doses of antipsychotics can cause insulin resistance at the level of the brain, separate from the level at the level of the body. And so we think that it is dopamine mediated, but we are trying to work on it. And once we find out, we will publish those findings, and hopefully we'll have another chance to meet where we can tell you about it.
Yes, please do. Thank you. What are your tips for having compassionate conversations with patients
Yeah.
who are concerned about weight gain and obesity as a result of their mental health medication?
Yeah. This is very, very important and clinically relevant. So, um, my approach is to defocus from the individual and to sort of not make it the individual's problem or shortcoming. I mean, already obesity has a more realistic sort of uh, color in our society and times where we think of obesity as a moral failing and not our inability to control our intake and not exercising. And so that becomes doubly problematic in the mental health context. And so what I try to do is to tell the patient and the family that this is really a pharmacological effect that's happening. This is the drug that is making somebody eat more and put on more weight and all of that. And so that helps defocus from the individual responsibility or the guilt. And then we talk about what can be done to make things better. And we focus around healthy eating, healthy activity levels, and then, of course, medications. Because oftentimes what happens is that people, it's not that they don't know that they are gaining weight, everybody knows they're gaining weight. And then they try to exercise or eat healthy, but they don't see the results, because they are sort of trying to work against the medication, right? And it's a lot of running to stay in the same place. And sometimes drugs like metformin and topiramate can make that more effective. So it does not preclude good diet and healthy activities. It just makes the results more evident and it helps counteract some of the pharmacological challenges that antipsychotics create. So that's sort of the strategy I take in the clinic.
Thank you. This question comes from a physician. I have a patient who has bipolar, PTSD, anxiety, and a trauma history, obesity, and diabetes. Do you have experience um, or input with diabetes treatment on complex patients like these? She's not managing well with multiple daily injections of insulin, and she's already on Ozempic.
Right. Thank you. It sounds like a complicated situation, and I hope she feels better soon. Unfortunately, no. My training is as a psychiatrist, and the expertise in metabolic health within mental illness is focused largely on prevention and early intervention before things like diabetes and heart disease and hypertension develop, because that's where prevention is simpler than treatment. Once diabetes develops, we tend to not involve ourselves and pass it on to endocrinologists and internal medicine people because diabetes is a multi-system illness in and of itself. And I don't think a psychiatrist treating diabetes is the best approach. So, yeah, no, unfortunately, no, but I'm sorry to hear that. And I hope she feels better soon.
Thank you. And I think we have time for just one more question. So the last question we'll ask here is, are patients who are on antipsychotics likely to experience less weight loss after bariatric surgery?
Oh, has Dr. Sokalingam already spoken or somebody from his team? Are they expected to speak?
Yeah, he spoke at the last one
Oh,
and
okay.
he'll be back next month. So
Yeah, so if you are attending that one, please ask that to him because he's the expert in this field. From what I understand from speaking together and attending some of his classes, is that patients with severe mental illness do tend to do pretty well after bariatric surgery. You, of course, have to make sure that the choice is made right, that they are stable and they are able to withstand the procedure. But having a diagnosis of severe mental illness does not measurably alter the outcome, and they do experience significant success with bariatric surgery.